I'm going to talk to you about bone healing adjuncts. It's a bit of a disclaimer. I'm not really an expert in this at all. And through the day, it's become apparent to me that there are quite a lot of experts in this in the room. So be gentle with me and feel free to contradict me. If we think about how fractures and therefore, this is in the context of non-unions, fractures and non-unions heal. Again, trying to keep things simple. I always like to think in terms of the mechanical environment and the biological environment, and I divide the biological environment into local biology and systemic biology. We've seen this before, so this is the idea that there are different components, and it's just a model for thinking about things. There are different components that contribute to the healing of a fracture or a non-union. And again, the mechanical environment is highlighted here, and we've heard a lot about that already today, but we always think about the presence of an osteoconductive scaffold, cells which can form bone, and growth factors which will stimulate those cells alongside a good blood supply. It raises the point that there is an awful lot of literature and research out there about the sorts of things we're going to talk about. And we've already heard today about some of the issues with translating work that's done in animals or work that's done in the laboratory, like ex vivo or in vitro studies, into what you do for your patients. That said, I don't quite buy the whole, we just have to completely disregard that information, because we have to start from somewhere. So there is a difference between having information, in my mind, that allows us to take things further in terms of the research, and if that's the only information that we have, it may be that we do need to use that to guide our clinical practice. But if we're going to talk about some of these adjuncts to bone healing, we do have to think, and these are pictures from the AO website. So that's an experimentally created fracture in a dog femur, not by me. And we have to consider that even with a catastrophic injury like this, bone is an amazing tissue, and because of all the evolutionary pathways that we've already heard about today, it can heal and remodel without intervention. So we have to think what we're doing if we want to add to that biology which is already present within the body. Similarly, not to labour the point, here's a patient with a non-operatively managed distal tibial fracture because he had a head injury and he wasn't going to survive, only he did. It went on to not unite. He had pain and difficulty weight bearing. We put a hexapod frame on him, gradually corrected it. No intervention at the fracture site, no bone grafting, no anything, it unites. And that's a well-recognised phenomenon. And you are stimulating the biology by stimulating the mechanical, or altering the mechanical environment and probably stiffening it and straightening it to achieve union. However, I do have instances in my practice where clearly bone grafts work in certain circumstances. So this was a gentleman who'd had a segmental bone loss in his femur due to infection. He'd had all of that removed, he's had the infection treated, he'd had a bone transport procedure using a rail, and this thing, the docking site simply would not unite, and I compressed it and I distracted it and I did all sorts of things to it for about a year because he did not wish to have any further intervention. And then he finally said to me, look, let's just do something. I opened it up, I stuck some bone graft and whatever flavour of adjuncts we happened to be using at the time. So he may well have got some BMP back then, which we were using. He may well have got some cells, although I think it was before we were using that. And 3 months later at United, we took the thing off his leg. So whether or not you have to bone graft it, in certain circumstances, it does work. So I think, again, you have to consider what you're using and why. If we come on to think about adjuncts in bone healing, these are the different properties that I'm sure we're all aware of. This is sort of basic orthopedic teaching, isn't it? That you can have, you have things that are osteogenic in that they are able to form bone, so they've got all the components necessary, the cells, the other components that you require to make the bone are there. And the real only example of that we really have is autologous bone graft. You then have osteoconductive agents, which are things that allow and promote bone ingrowth, and they act as a scaffold for the cells to live on, and they support the healing. And then you have osteoinductive agents, which you've heard about already, which appear to be able to initiate and promote bone formation as long as they are in the presence of the necessary biological components. And these are things like the BMPs. And we would like all these things to facilitate vascular ingrowth to support the biological process. So I'm going to talk very briefly about these things, and I'm going to give you a very brief literature overview. So allograft, I've never used allograft. I don't really know very much about it. It's clearly human bone from another individual. a live donor or post-mortem. Doesn't contain cells because of the way that it's been treated to try and reduce the risk of disease transmission. Demineralized bone matrix is a highly processed allograft, so it's a form of allograft which contains BMPs and is therefore felt to be also osteoinductive. It's used predominantly bone loss in arthroplasty and for periprosthetic fractures as strut grafts. Again, it's felt to probably only be osteoinductive. It's very expensive because of the processing and storage required. It has variable mechanical properties, risks, and there is a risk of disease transmission. It has no role in my practice in non-union management. I think some people may use it for very large bone defects as a graft expander. Brief touch on demineralized bone matrix, probably osteoinductive and osteoconductive, although it varies depending on the preparation used. Again, we've already said it's derived from human tissue. There is therefore a theoretic risk of disease transmission, although I understand there's been no reported cases of that. Many different preparations are available and they all have different components. Systematic review in 2017, 64 manuscripts, 4 randomized controlled trials. When they looked at the cases where it had been used in non-union, it had largely been used with other modalities. And this is a problem with the clinical research in these areas. People often use multimodal therapy and then you don't really know what's worked and what hasn't. And the conclusion of the systematic review was that evidence was limited and these were largely of poor quality and they couldn't offer advice on using it in non-union surgery. Go to growth factors. We've heard quite a lot about this already today. So we're talking really about recombinant bone morphogenic proteins. They're osteoinductive via osteoblastic proliferation and differentiation. BMP2 is licensed for open tibial fractures and anterior lumbar interbody fusions. There was a nice trial that was done early on, I think it was an American military trial, showing increased union rates and reduced reoperation in open tibial fractures, not in non-union. But there's been a more recent RCT which contradicts that finding, found exactly the opposite. Well, not exactly the opposite, it had no effect, so it didn't make it worse. I have used it in open fractures, and I think what was described earlier about having a very florid initial inflammatory response is true. I don't always see it, but I've definitely seen it. It raises massive alarm bells about infection. It's very worrying for a period. The patients don't like it because it's painful. BMP7 has gone at the moment due to manufacturing and commercial issues. There's probably not a lot to say about that clinically. They're expensive. They risk ectopic bone formation as well as the other things we've talked about. There's a meta-analysis of using BMP with autologous bone graft recently published, and they said there was no difference when they conducted the meta-analysis, and therefore they said they couldn't support its use in combination with bone graft. Platelet-rich plasma, these are the patient's own tissues used. It's derived from centrifugation of the patient's own peripheral blood. You take a blood sample, you put it through a specific centrifuge which draws off the part of the blood which you wish to use. The PRP is then extracted and either injected or mixed with something and put into the patient's body as a graft. It contains significant amount of growth factors which are involved in bone healing, and therefore from a basic basic principles perspective, it should have some use. It's been shown to recruit mesenchymal stem cells and promote angiogenesis in particular. It's been demonstrated to be osteoinductive in vitro. And there are a number of observational randomized control studies which suggest effectiveness in the treatment of non-union. Interestingly, even in isolation, so if you had a stable non-union, simply injecting PRP, and I think I saw something a while back, I couldn't find this just now, where it had become the most popular non-union procedure in the US. Now, there may be reasons for that, and that may be incorrect. I couldn't find that today, but that was a couple of years back, I recall seeing that. But you've got to have a stable situation. You should really be free of infection. Again, there was a systematic review and meta-analysis, which I didn't really understand this, but the explanation was that it was not favouring control, as the top seemed to show. It's due to a number of events. Their conclusion was, even though there were only a small number of studies in a limited number of patients, that the conclusion was that there was evidence to suggest it had utility in the management of non-unions, even used in isolation. Move on to stem cells. We've already talked about those a little bit in previous talks, so I won't go into that detail, but they're found in low concentrations in bone marrow, and they're involved in the natural bone healing pathways. The process by which we obtain them is usually from a iliac crest aspirate, and then the cells are concentrated to extract much higher concentrations of the mesenchymal stem cells which we wish to use from a large volume of aspirate to give you a smaller amount you can use effectively in the non-union site. It may provide a direct source of viable cells which can contribute to bone healing. It may provide growth factors, and I think the conclusion seemed to be that the true mechanism of action was clearly not fully understood, but it was very clear that the growth factor, the growth factors which were there and the types of cells were present were very different from that which is present in PRP. So you weren't doing the same thing, it was a different mechanism. Very nice literature review. Professor Sharma's name at the bottom, looked at the published studies, identified the numbers seen in front of you. 66 studies looked at non-unions, although 29 of these studies had yet to report, so they were looking at what was a lot of research still ongoing. They raised concerns about study quality and the risk of bias in those studies. The studies were very, very heterogeneous in all aspects, including the reporting, the outcomes used, and in fact, the actual methods that were being used. And one concern that was raised, it was very unclear what was actually being put into the patient's body because they weren't measuring the concentration of the cells or they weren't reporting it. So you couldn't really understand if it was failing because it doesn't work, so it's not efficacious. It doesn't work in principle, or it's not effective in that the surgeons were unable to deliver the cells effectively without using the technique in question. Overall conclusion, however, that there was insufficient evidence to comment. Further lit review in non-unions, and this looked more specifically at percutaneous bone marrow aspirate concentrate for non-unions, similar to what we just spoke about for PRP, so simply injecting it into non-union sites in a stable, uninfected environment, quite a large number of patients, and they found that there was evidence to support that in clinical use. And I thought this study in particular was quite interesting. And it's quite from, quite a long time ago, nearly, we're getting on for sort of 17, 18 years ago. So 60 aseptic, stable tibial non-unions, 88%, I think that should be united. But again, the concentration, they looked specifically at the concentration number of cells injected, and that was significantly lower in the patients who didn't go on to union, and there was a direct correlation between the volume of callus in those who did unite and the concentration and number of cells that were injected. So there does seem to be some evidence that it probably does work if used in a certain way. Move on to bone graft substitutes. It provides an osteoconductive scaffold without donor site morbidity, loads of different preparations. Can be used certainly in fracture treatment, provide mechanical support or as a void filler. I use it a lot as dead space management and to deliver antibiotics in infection work and in some open fractures. These are the different substances that are used. Systematic review in 2013 in TNO. Evidence was generally of very poor quality, very little evidence at all in non-union surgery, insufficient evidence to support use. And to my mind, unless you're using it with something else, so I do use it as graft expander. Again, I use it for mechanical stability in certain situations, but I wouldn't use it thinking I can put it into a gap and make it heal, although obviously its osteoconductive properties may be of some benefit in certain situations, but I think its use is relatively limited in non-union surgery, particularly when used in isolation. Quickly talk about exogen or low-intensity pulsed ultrasound. It's a non-invasive method. It's inexpensive compared to surgery, although it does have a cost to it. And it provides indirect mechanical stimulation, which leads to biological activation at the fracture or non-union site. There's quite extensive basic science work that shows that it can enhance angiogenesis, cellular recruitment and differentiation, and callus mineralization and remodeling, so all the different phases of healing. There's systematic review, and probably the most recent one, certainly the most recent I could find, the one that gets quoted a lot is that from Zura. 82% of fracture or non-unions healing, these were stable instrumented non-unions, and it also reported in osteoporosis and indeed in infection, which I certainly haven't used it in cases where there's been infection, and got similar results actually. And the NICE guidelines in the UK currently support its use in non-unions. I think there's been some confusion about a relatively recent BMJ systematic review saying it had no benefit, and people kept saying, oh, actually, it's no use, don't use it. But that was in fresh fractures. And if you talk to people who work in the area, although they may have links with industry, so I think you also have to be careful of that, they've raised some concerns about the conclusions that were drawn in that study, particularly when you look at the fact that compliance was only about 44% in the studies that were considered, and therefore they're saying, actually, this may again be a failure of effectiveness. So actually it didn't work for those patients, but it wasn't because the modality doesn't work, it's because it wasn't being delivered appropriately. And I think this is quite a nice paper if you're going to use it, because it talks about how you should employ it to get good results. And it presents some evidence to support it, but basically the conclusion is you've got to have a fracture gap of less than 10 millimeters. The fracture has to be stable. You need to very accurately place the device and make sure that the patient does so when they're using it. You need to give it long enough, so you need appropriate treatment times, and you need to be very clear with the patient that they need to be compliant and use it every day. So when we place them in clinic, we put skin markers, these are expensive paperclip skin markers, take an X-ray and then mark on the skin and get the patient to keep that on. Interestingly, when they first told me I didn't know where the non-union was in my patient, I was like, don't talk nonsense, of course I do. And so I started doing this anyway, and then I guessed which paperclip it would be, and I was wrong absolutely every time. So it absolutely showed me that you do need to, well, I do, maybe you don't, you need to target it radiographically. You can't just guess. Whether it was effective in this case, I don't know. I think that's after about, I think it's about 6 months of treatment. It's probably, I have to say, I wonder if it's simply different penetration of the X-ray that makes it look different, but her CT did look favourable, and she doesn't wish to have surgical intervention, and her implant is intact. So whatever, it's entertaining me and the patient while she doesn't have an operation. I've just thought this graph, oh, hang on, gone past it, was quite interesting from that paper, which they'd done some manipulation of the data available and done some propensity matching and all sorts of funny things with statistics, which always makes me a little bit nervous that the results may not necessarily be meaningful in clinical practice. But it did show that you probably do need to wait a significant amount of time if you're going to use Exogen. So if you look, the red line's at about 3 months, and there's not really going to be very many of those non-unions healed at that time. If you go to about 6 months, which because of the scale, I'm not sure I've been accurate, that's my yellow line. But you see, you're getting a much bigger yield of united non-unions at that point. And the green line's at about a year. So if I do use it in patients, I say to them, you know, we've got to invest the time to make this worthwhile. If you're in too much pain or you're going to get fed up and want an operation after 2 months, this is just a waste of money. So let's think about doing an operation. And I do what is described as poor practice in the paper of offering it to patients whilst they wait on their waiting list, because we have quite a long waiting list. So in conclusion, I'm going to show you a very quick case and then move on because I'm over time already. But I do use these things, but I use them in a way that they are not supported by evidence, except clinical experience and case series, in that I use them in combination in very severe situations, usually with bone loss. So this was a guy who had an infected open fracture, came back from overseas, horrendous injury, debrided, X-fix was already on, it wasn't great, debrided some more, spanning plate and massive bone defect. So you can see he's missing all of his distal radius and ulna. So we put that on, we put a cement spacer in, he had a free flap, and rear-harvested bone graft every, I think he had bone marrow aspirate concentrate, PRP. I think I probably used a bioglass graft expander because it had previously been infected, and it united, and he kept his arm, which he was quite pleased with. His function was relatively limited, but he has achieved use of that hand. So my conclusion is I use it, but I can't really support it with good evidence. And that's it.